Welcome everyone, wherever you are, to our public discussion. I welcome you on behalf of the Society for the Study of Sudan and South Sudan, or generally of the Sudans, SSSUK in brief. The topic of our discussion today is the coronavirus epidemic or pandemic, as it has been recognized, and how it specifically is affecting these two countries, Sudan and South Sudan, as well as the UK, where several Sudanese and South Sudanese live, and where also there is a sizable number of Sudanese practicing doctors. This is the topic today. We will look at this virus, which is said to be nothing like we've ever seen before. It has devastated powerful economies, powerful countries. The question is, how do weak countries, weak states like Sudan and South Sudan, and the relatively very poor communities, how likely they are able to face up to this threat? Are there resources that are available that they can capitalize on? Can they do this alone without external help? Are there experiences in other countries that they can benefit from? So these are the questions that we are thinking about, and we are relying on our panelists and our audience in general to address these questions, discuss these questions in what I hope is going to be an engaging and useful discussion for all of us. Our distinguished panel is composed of three Sudanese doctors, South Sudanese doctors, and a British expert on Sudan and South Sudan. Hopefully, a lot is going to come out of this discussion. They will lead our discussion. And after that, the audience will have a chance to address questions to the panelists. Each panelist will have a maximum of about 6 minutes, which would be nice to adhere to, because that should be sufficient for them to deliver the central message while leaving the details to the questions and answers session that's going to follow. So without further ado, in the order of their appearance, our distinguished panelists are Dr. Sarah Abdul Jalil. She is the president of the Sudanese Doctors Union in the UK. Dr. Aluzaya Hakim, he's the associate editor of the South Sudan Medical Journal, which is issued in the UK and South Sudan. Dr. Marwa Jibril, she is a Darzi Fellow and an NHS GP in Britain. And finally, and not least, Dr. Nikki Kendersley. She's a research fellow at Pembroke College, Cambridge University. These are our panelists, and without further ado, they will start. We welcome Dr. Sarah Abdul Jalil to present us her message.
Good evening, everybody, and thank you, Marwan. And I'm very privileged to be speaking in your platform today with such distinguished speakers. And I welcome all of those who have joined this public event. From the Sudan Doctors Union UK, the COVID-19 pandemic has been a very, I can say, a new experience. In the past, we have been involved in humanitarian aid in Sudan, but this time, obviously, we are facing the pandemic ourselves, being the frontline health professionals in the NHS. And therefore, it has been double the fight while we are in the UK and while we're thinking about Sudan. The pandemic, we don't have a lot of evidence-based information, and this is very difficult for clinicians. We are dependent on the best information available and sort of sharing the information among ourselves and trying to learn from the information. So people have been trying to support each other as members of the Sudan Doctors Union. And sadly, we have lost 5 of our colleagues during this fight. Lately, yesterday, we lost Dr. Abdul Wahab for COVID-19. So emotionally, psychologically, this have been affecting us. but we continue to work closely with the Sudanese communities, trying to convey messages about health services, access to health, how can things, what should you do with the COVID-19? For example, Marwa kindly have done a talk for us about COVID and pregnancy, COVID and diabetes. So we're trying to fulfill our duties as well towards the community, despite the fight that we are facing in the NHS. At the same time, obviously, we have been linking to Sudan with the Federal Ministry of Health and with other colleagues there. We were very concerned because we all know that the health system in Sudan is very fragile. We know there are issues about the ban on, like money transfer. We are aware that, countries like the UK, like the United States and other countries are struggling to get PPE, to get enough equipment. So we are very worried about how things will be done for Sudan. And obviously there are major struggles. As usual, there has been donation and there has been a campaign, and we are heavily involved in the campaign related to oxygenation and monitoring, trying to support oxygenation in the states outside Khartoum, not only in Khartoum, but other states, because there has been now spread of the disease in about 10 other states. Because it's a global fight, we have to face it together. And together with other Sudanese groups abroad, we formed a coalition so that we have like a dashboard. We exchange information, we know what we are doing, we don't repeat each other work, and we support each other. And that's in Canada, Australia, New Zealand, the US, Ireland, and Qatar. And this coalition has been very successful, in particular about trying to direct donors about what they should do for Sudan. I would like to say that we are learning every day about COVID-19, whether in the UK or in Sudan. But the most important thing is data collection and having information and research. And this is why we would like to work closely with Sudan, because a lot of information can come out from there that can help the people. There are a lot of challenges about the lockdown and about the economical support and social distancing. And I think this pandemic have exposed that health and prevention have not been the priorities in a lot of countries, not only in Africa, but even in other countries. Thank you.
Dr. Olusai.
Thank you very much, Chairman. It's great to meet colleagues to discuss issues of common interest, not only globally, but specifically focusing on Sudan and South Sudan. I'll just go through a few points which I had prepared earlier. One of them is that the COVID-19 is a new disease. Nobody knows much about it. Studies are ongoing internationally, and there are a few centers in the UK that are looking at various aspects of the disease. But most importantly, there are efforts to try and find vaccines and drugs which work. But until that happens, the best way forward is prevention. And in order to be able to prevent the spread of the condition, we need to be able to test people. There was a study from the University of Florence in Italy when the professor tested an entire village of 3,000 people. And he actually found that there were about 78 people who had no symptoms whatsoever who had COVID-19. And by isolating them, they were able to drop the number of those who had improved from the 78 to only 7. So it just shows that this is a very effective way of doing it. At the moment, this is going to be very difficult in the South Sudan unless we have a facility for isolating people. Yes, in the rural areas, it may be different, but my own suggestion would be that any aid that goes to South Sudan must be in kind, not in money, because procurement is going to be very tricky. South Sudan is landlocked. The neighboring countries have got their own problems. And so if there is any aid which is going to come in, predominantly, it must be in kind. For example, prefabricated panels for making units for isolating people. We can use solar to light and possibly to provide cooling systems for those areas. Otherwise, we cannot talk about isolating people in the metropolis of Juba. Then the other thing, of course, is that the task force, the COVID task force in Juba ought to contain in its membership a consultant in public health, a currently practicing clinician in the hospital to be able to give them details of what is actually going on, how serious the conditions are, and the provision of personal protective equipment. If these are donated and sent to South Sudan, they will go very quickly, and there will be no problems with procurement or the logistics from South Sudan. But obviously, we need some money as well to try and fund people who are very keen on South Sudan, like Dr. Kindersley. But that should be part of the help in South Sudan. And apart from the testing, isolating people, and making sure that they're actually monitored, we need testing equipment to be donated. Once test equipment is donated, then we can test more people and identify more people. At the end of all this, we need to improve the health services in South Sudan. A lot of South Sudanese who have been able to raise the money have traveled to East Africa, to India, to South Africa for medical treatment. This has got to stop. What we need to do is to improve the health services. And I think I advocate a two-pronged attack. One is development of integrated health, primary health care in the rural areas to cover about 90 to 95% of the people, and small, efficient, and workable hospitals in a few selected areas where patients can be transferred if they need hospital management. This is quite an important, it's going to be an important outcome of this COVID. I will sort of stop there because I've made a few points and we can sort of answer any other questions that come later on.
Thank you very much for your contribution, Dr. Rizai. Next, Dr. Jibril, would like to hear from you.
Thank you very much, first of all, for having me today. It's a privilege to share this platform, as Sarah said, with all the distinguished guests. And I think it would be very important, of course, to try to have this discussion, to learn from each other, especially from our neighboring sister, country in South Sudan and elsewhere. Sarah has said a lot about the situation already in Sudan, and probably I would like to talk about a bit more about, the unique situation in Darfur, because it is a conflict area, and I still don't call it a post-conflict zone because still there is conflict going on. Darfur, if I just shine a light, before the corona, it's a region as big as France with nearly 9 million, the population is nearly 9 million people, and there has been a war in the region since 2003. And as a result of that, many people unfortunately lost their lives, or nearly 3,000 people, and a good few millions. So there is a suggestion that, according to the United Nations reports, as more than 3 million people now are displaced either internally or even in the neighboring Chad. And we see there is a large number of camps in different states, the 5 states of Darfur, so the north, south, west, and the east and the middle of Darfur. And of course, the health system, as a result of the war, is one of the, it's hugely impacted. We can see that there is very poor infrastructure in terms of the hospital buildings, equipment, planning, and the distribution of all these centers, as well as, of course, the health professionals. We don't see that there is enough health professionals. There isn't enough health professionals, and even the ones that are there, they're always struggle with the training they have. Of course, as it is, and we see people travel quite long distance, sometimes miles and miles, to get to the nearest health center. Now, of course, after the corona, and now Al-Fashir and Darfur, it is recognized as one of the the states that's been affected by the COVID-19. We had a recent doctor, unfortunately, who passed away 2 days ago from Al Junaina Teaching Hospital, Dr. Abu Bakr, and more than 10 doctors had a COVID positive test, and they were all working in the isolation centers in the hospital. And you can imagine when very few doctors already there, and they are out of service because they are isolated or isolating. So we heard report over the last few days, there is a large numbers of elderly who are dying on a one day, more than 30 or 40, nearly 40, so that the numbers are not very clear, but people report that between 30 to 40 patients would die per day, mostly elderly, in a very, very, not very wide neighborhood. So people know that there is, a lot of deaths going on. And the problem, I think, what's currently in Darfur is, of course, what is happening in the whole region is, or the whole country struggling with providing testing and isolating centers and health personnel. But also what happens in Darfur is that in the whole region, there is no one kit to test. The region is as big as France. A test will be sent to Khartoum for a lab in Khartoum, and this takes for up to 5 to 6 days before they can get a result. So you can imagine the situation in the region. There is one isolation center per each of these states, and the isolation center, I just spoke to a colleague in CAS, and he said the isolation center in El Junaina, for example, got 10 beds. So people come from far because, of course, it is a wide area. They travel for a long time, and when they arrive, a lot of them sometimes can't find a bed to be admitted to isolation center. The other, I think, issue is important to talk about. There is a lot of camps, refugee camps. There is overcrowding of these camps. There is no necessary running water on these camps. So the basic prevention from COVID is contracting COVID is not there. So as much as I would say the situation, as I said, in the whole country is difficult and very challenging at the moment, the Darfur situation, I would say it's more dire because of the the fragility of the health system in the region. And I will stop there to hear more and respond to questions.
Very much for the very informative information about what's going on in the war regions, particularly Darfur. Dr. Nikki Kendersley, could you just also add your message here?
Thank you, and thank you for inviting me to be part of this very impressive panel. I second Dr. Sarah's note that this is a global challenge facing our global community. So I'm presenting some new research findings from some very rapid response research conducted by the Rift Valley Institute's South Sudanese research team with myself to understand local knowledge about epidemic management and responses to COVID-19. So I'm speaking on behalf of my 9 other colleagues, Joseph, Turillo, Elizabeth, Gatquoth, Javencia, Abraham, Mao, Machot, and Ahide, to give them credit. Together, we undertook rapid interviews and meetings in a socially distanced way and by phone across urban and rural and village farm cattle camp spaces in 11 places across South Sudan from all communities, all corners. And we did this over the last 3 weeks or so with about 2 weeks of very intensive work. The short research note that we produced is now available on the Rift Valley Institute website if you're interested. So I'm just going to present some key headlines from our work, 6 short points, I hope, on lockdown and on South Sudanese people's response to the virus in the country, on rumours, and on community stratagems for epidemic management. And what I'm about to present is based on the analysis both of the South Sudanese research team and the residents that we interviewed during this research. So firstly, lockdown, while probably the best transmission prevention method, is not likely to be enforceable in South Sudan without violence and famine. The lockdown that happened, it actually was creating more crises than it's solving. Medical personnel understand that its aim, the lockdown's aim as applied internationally, is to minimize transmission, to buy time for health and infrastructure to prepare. But, you know, as Dr. Hakim and as nurses in hospitals across South Sudan told our researchers, they find this laughable. One nurse said, "We're deceiving ourselves. We can't even contain malaria. We can't deliver babies safely." So because the virus is effectively attacking the rich, South Sudanese and internationals first, the lockdown appears to be a sacrifice of the poor for the sake of the self-protection of the elites. And the security services are already profiteering off the lockdown across the country. We're finding lots of examples. So epidemic mitigation via community consultation and locally led action is likely to be much more effective than a securitized lockdown. It would also give space for building local variations of movement restriction, isolation, and contact tracing. So secondly, while people are hearing about the coronavirus, there's little ability or incentive for most people to respond. This is both because prevention tactics and social distancing are impossible for most people's livelihoods, but also, more importantly, there are other just as pressing medical and practical threats to life, including cattle raids and other local violence, the locusts, impending locust problem, and famine. And as one woman said, the lockdown's economic crisis and famine will kill all of her children, but the virus might only kill one. So thirdly, many South Sudanese people are deeply offended that it is the virus that has stimulated a response from the government and the international community, rather than these other pre-existing or continuing immediate dangers and life-threatening problems. Members of the public and our team suggested that the response needs to take into account the other crises and traumatic life events that communities are dealing with, moving beyond one-way top-down organising to two-way conversations about the wider medical and personal threats to health and life in communities, into which coronavirus is entering and complicating. Fourthly, information about virus vectors, about symptoms and prevention of transmission is fundamentally insufficient at the moment to persuade people to participate in actions that contribute towards the suppression of the virus. And community mistrust in government is often underestimated in South Sudan. With minimal trust in government or in external authorities, people need to understand viral transmission dynamics in order to organise comprehensive local responses. And this was reflected in all of the Ebola response analysis in West Africa. Locally organised responses there were critical in stopping the spread of the virus and were organised when local people were given enough information to think like epidemiologists. So provision of more detailed information on disease dynamics can help communities engineer their responses and improvise quarantine, personal protection equipment, and containment. Fifthly, local epidemic management systems already exist. So for example, we heard that in Northern Bahr Ghazal, communities create barriers around infected households, have methods of transferring water, milk, firewood, and food without sharing containers or coming close to the household. Villages have been previously quarantined, wells have been allocated in past crises, urban travellers have been identified as vectors in old epidemics and quarantines. Cattle camps also have their own quarantine and movement restricting systems in outbreaks, including separate water and grazing points. And so we need to recognise local medical expertise of, for instance, healers, midwives, and pastoralists, even if it doesn't correspond with current scientific standards. Without this recognition and respect, there's going to be no uptake. For example, we heard that cattle camp leaders turned back a medical team in Ural on the 8th of May. So these local methods might not on paper best minimise the risk of infection, but they will hold more confidence and consent. And building trust and collaboration in upgrading these systems and putting them in place needs two-way conversations. So finally, on rumours, we all know that there are more rumours circulating than official information in South Sudan, not just about the coronavirus. Rumours cannot just be contradicted. In many respects, this just fuels the rumour. Instead, they should be treated as political statements, because many of the roots of these rumours are actually fair, if medically inaccurate, observations, although the Sinar prophet baby might be an exception. It is fair to see this epidemic as spread by the rich, those who can fly about the place and pick it up, and borne by the poor who cannot access medical treatment. Other rumours are also politically significant. For instance, the rumour that cases are not real but have been faked by the South Sudanese government to get international money. and that it's not a disease that affects Black people, because in international media we see Black people doing the deliveries for white people in the US. These seem like reasonable claims for many South Sudanese people. Similarly, the rumor that disease is the coronavirus is a Western invention for depopulation of Africa to harness resources fits reasonably well with genocidal imperial histories in South Sudan. So for all of these rumors, more comprehensive information about the virus, its spread and effects elsewhere will be probably more effective counterweights to this rumor mill than simple denials from on high. So with that, I'll end. Thank you.
Thank you very much for your summary, Nikki. I think the first question that people have raised goes to you, Dr. Hakim, and is to do with that there seems to be a strike in Juba, and all the work towards coronavirus could be affected by this. Could you elaborate on that if you've heard anything?
I read about the strike, or the said strike, in Radio Tamajus, and text someone in Juba, but he said he never heard of a strike in Juba. So I looked at the iRadio, I think it's a UN-run radio, which operates out of Juba, and one of the main items on their website was that the strike had been called off. But the reasons given were that the doctors had not been paid for 4 months, and that they had been promised salaries and these ones had not been paid. So I really do feel that the government has a duty of care to the doctors, because they are the front line, they're really the frontline people in this war against the invisible enemy. And they ought to feel that they're being cared for. They ought also to feel that they've got armor in the form of PPEs. And in this case, we really need a practicing clinician to be a member of the task force, so that at least information that exists within the John Garang unit, where all the acute cases are managed, can be conveyed directly to the task force so that they can take action. But it appears the so-called strike has been called off. So we wait for further information.
That's brilliant. Thank you for that update, Dr. Hakim. There's a question for you, Dr. Abdul. And actually, it's a question from somebody from Washington. The name is Manal Taha. It's a long question, but I'm going to summarize it. Basically, it's saying that while private money is going into Sudan, the government is crippled. Government finances are crippled to be able to finance the health measures because of the sanctions. As long as the sanctions against the government remains, the resources are not filtering to Sudan. Can you make a comment on that?
Yes, thank you very much, Manal. Obviously, the ban on the money transfer has been a big issue, and it continued. So if we want to transfer money to Sudan, it has to go through the black market, which we wouldn't do, and we would try to avoid this. But then getting the money in Sudan is not the solution, because we know that there is a very limited local production, for example, for PPE or other equipment that's needed. So then they have to transfer the money back outside Sudan to export things. So there is a delay in time. That this delay in time can affect life. We can lose lives. At the moment, the problem with PPE, the personal protective equipment, the shortage has been affecting the health professionals. Some of them are panicking. It's not an easy thing to do. It is like a war. And if you go unequipped to do your work, you can get the disease and you can die. There is a lot of issues related to the money transfer. There was an effort to open a bank account, an official bank account, so we can transfer money, but we failed. And therefore, we have raised our concern to the Troika group in Canada, US, and Australia, that at least we need permission to transfer the money officially without going through the black market to an official bank account. As we stand today, we feel that the United States is the main player and have to review this request.
very unfortunate, but we await that this message probably gets through and maybe things will change during these terrible times. There is a quick message to you, Nikki. They didn't say the name. They're saying they totally agree with you that in a third world country like South Sudan, a lockdown is not a solution. They would like to hear more about your research. How effective is it? How generalized can it be? Is it in South Sudan? And specifically, how has it been the response? I mean, have you been able to identify whether people are actually responsive to the epidemic and the message of the epidemic?
Thank you, Moan. So a note on methodology, everything I just summarized and the summary presented in the notes published last week, I think, was common to all responses across all areas, because we wanted to present a united understanding of what's happening across South Sudan. We're going to attempt to break this down, I hope, to a kind of regional and local and a view, but at the moment everything I've just presented was common across accounts that we were getting. In terms of community response to the coronavirus and also to the coronavirus effects in terms of the lockdown and the economic crisis that it precipitated in South Sudan very rapidly. First, the community response to the coronavirus, it was extremely mixed and completely depended on whereabouts you were. We found actually that the radio coverage, which has been the kind of main efforts to get out a coherent message about what the coronavirus is and how to protect yourself against it, had actually not reached very far beyond the urban areas. Within the urban areas, people were really struggling with the economic effects of taking the precautions. So market traders, women traders who most people rely on daily income in urban areas. And if that's interrupted for even a day, it becomes impossible. However, in the rural areas, and particularly in cattle camps and on farms, people had either not heard of what was happening, or had heard rumours, or had heard that you just need to drink tea before 4 AM without sugar, and all of these things. And there was very little understanding of how it differed from flu. And I mean, the fundamental thing that people were saying was, regardless of what this thing is, where it came from and why it's happening here, and how severe it actually is, regardless of all of that, the problem is, why is the international community, why is our government implementing such dramatic measures, such major interventions for this rather than anything else? Why have they ignored our problems on everything else other than this?
There would be actually further questions on that coming. But for now, there is a question from somebody who studied, Rosin, had studied in Manchester University. It says that there have been rumors circulating that health workers have been attacked. And I think she did not specify the country. So I think it's only fair that I would ask Sarah and Eluzaya to comment on this in relation to each particular country. Go ahead, Dr. Eluzaya.
One of the complications of a pandemic, in fact, is that people become very aggressive towards healthcare professionals for reasons which nobody understands. I listened to a streamed lecture from Canada by a psychologist, and he said that situations like panic buying, aggression towards people of a different ethnic group or different racial group, attacking healthcare professionals are very common and have no reasonable explanation. They do happen, and in this.
So have you heard specifically?
Yes,
about these cases?
I've read about it. Some nurses and some doctors have been aggressed in the UK. Because
South Sudan?
No, South Sudan, no.
Okay.
Because the disease is still pretty new.
It's very interesting that you mentioned the UK, to be honest.
Oh, yes.
Given all the knowledge that's supposed to be here.
If you look at the BBC app, I think that there was somebody who was verbally aggressed by some
in South Sudan.
No, here in the UK.
Okay, thank you for that. Thank you for that.
South Sudan, no.
Yeah. Let's hear the view from Sudan, Sarah. Have you heard about any violence directed at the health workers?
In the last month, there has been some violence. And I think it all comes to understanding about the disease. There are new implementations about people cannot come in with their relatives. We have to cut on the, crowding in the waiting area. There is as well, most probably, frustration about access to healthcare. Marwa have given some examples. The Sudan situation is still fragile. So people are panicking. Those who know about it are panicking. Do I have COVID? I don't have COVID. Should I go to the hospital? Maybe I will get the COVID. No, I will stay. And then there is delay in presentation, and their loved ones are very sick. So unfortunately, it is not the responsibility of the health professionals per se, but they are the one who are the front line. And this is why we have released a video from us doctors abroad to support our colleagues in Sudan, talking that there is a zero tolerance for any sort of violation towards health professionals.
Thank you very much. That's a terrible news to hear. There's a more general question to both sides, really. Is saying about has primary health care broken down in South Sudan and Sudan in recent years, and what can be done? What can be done to resurrect primary health care? Maybe I should ask Dr. Jibril to have a say there, and then I'll come back to both of you.
Thank you very much. I just wanted to make a comment, and I don't know whether you managed to see me. So with what Sarah said in terms of violence against the health professionals, especially with the frustration that people have because of all the lack of, and difficulty in the service. Also, it's worth mentioning that there is no laws that criminalize attacks against health professionals. And one of the main things that we are calling for is this act to be criminalized, so people for it to work as a deterrent. As much as we can, work, I think, side by side, the law, but as well as, raising awareness, they need to be a law that enforced to prevent people from attacking health professionals. At the moment, health professionals are not protected. And to go back to the question, so I think the question of the primary healthcare is the main, I think, the question now. It's been brought up. Of course, we inherited in Sudan a health system that is very fragile, suffered many years of a lack of funding, and as well as brain drain of the health professionals. A lot of us are outside, living here in the UK, in the US, and Ireland, and all over. And we see that there is a continuous, loss of the workforce. So what we, I think, need to be done is, of course, having a collaborated effort between all the regions, so between the Federal Ministry of Health and other regions as well. After, of course, we hear that there will be a higher and the funding for the budget for the health service would be increased. But I think unless we have a planned a plan to implement a wide primary healthcare system in all over Sudan, I think the health service will continue to suffer. Currently, people are traveling from very wide regions to come to a very centralized health service in big hospitals. And of course, those hospitals suffer from a large attendances. And of course, not all people have the ability to reach the hospitals in a right time to receive the service. So we see more poorer or later presentations. I think one of the main steps to start to reforming the health system in Sudan is building the primary care health service, strong primary health care service, especially in a country where, as I said, is a vast area. A lot of health services, small centers can help with the immunization for children, basically primary care, providing primary care to prevent people seeking health to the center. And not just that, I think that also has economic implications, because a lot of people, as soon as they start to have some prosperity, they tend to move their smaller towns to bigger towns where there is more health services, more schooling, and so forth. So I think if we're looking to decentralize more of the service to the regions, with having a clear and a strong primary health care, so I think this will be the first steps to reform the health system.
Thank you. I'll come to Dr. Luzai because I know your special issue of the South Sudan Medical Journal has spoken very widely about coronavirus, and some of it is about primary health care. I'll come back to you. But I wanted to come to Dr. Kindersley about her paper, because there is a question here in relation to the healthcare, which I want you to come on, this primary healthcare that I want you to come on, which is, I wanted to see also to what degree is what you were talking about in terms of local resources of past experience of dealing with epidemics. How is that actually understood in Juba in relation to the high structure of the COVID-19 task force, and how that is obviously related to primary health care? And also if you could add to that a simple one as well, which is, why hasn't anybody mentioned to help to tell villagers this is just the basic way to do it? And I would probably want other people to comment on it later on as well. Thanks. Your chance, Dr. Kindersley.
Thanks. I can't necessarily speak to how this type of research and these types of points which are being raised by other people better than me, I think, are being taken up by the central response in Juba, partly because I don't have access to those forums, although I'm trying to kind of promote this. The Rift Valley Institute is trying to promote this approach to the highest levels. At the moment, though, in my opinion, the response in South Sudan, the official response in South Sudan has been highly centralized, highly governmental rather than medical, as Dr. Hakim notes, and also highly kind of Western medical, which is fair with the pandemic. I don't want to do that down, but at the same time, it has very little recognition of the two-way conversations that this research highlights as critical. And is very much focused on one-way messaging about what people should do. So it's also very directive rather than collaborative. So that's my perspective only.
So you say that would be hampering, the development of primary health, and also adversely affecting communicating the message, raising the awareness of the people about the pandemic.
Absolutely. It's no secret that people are frequently extremely hostile to that type of approach from the government, an incredibly kind of directive and officious approach, but also the lack of clear explanation of why everything is happening and what exactly this thing is. Like I said, the kind of detailed information that people need in order to actually organize their own responses isn't there. And the lack of a collaborative approach is really stopping people from being able to organize their own responses with kind of the best possible information and the best possible advice. So I really hope that this is a shift. I'm optimistic that the shift from complete lockdown, away from complete lockdown, is promising and a sign that this is a direction that people are going in. And I just wanted to comment on the soap. This is a message that is really common across South Sudan. People are really picking up the fact that you need to wash your hands. However, soap is, expensive, and in particular remote locations is not accessible. I would really like to see some public health advice on the utility and the effectiveness of using sand, and, as many cattle keepers told our
substitutes,
the possibility of using cattle urine as well, which is the is the disinfectant that they use. So.
Yeah. Okay. Dr. Hakim, yes, yeah. Could you say that as well in relation to soap as well? And well, about primary health.
I would want to comment on primary health care, but I am talking about integrated primary health care. There is actually an article in one of the issues of the South Sudan Medical Journal. If you go into www.southsudanmedicaljournal.com and just type in the box integrated primary health care, there is a very extensive article that Victor Buni, who is a public health consultant, and myself wrote, because we're really fed up. There is no proper public health template anywhere in Africa. Since 1978, when Alma Mater recommended primary health care, not a single child was vaccinated in South Sudan. We had lots of Land Rovers, people coming from all over the world, primary health care, but they did nothing. And this has bugged me for years. And so we've decided that integrated primary health care would be the best possible way. Integrated because you would have public health measures, you would have minimal treatments, because most people in the rural areas don't really need heavy Western medicine. And a lot of doctors are trained to diagnose and treat, but not many people in the rural areas are that ill. They suffer from malaria, they suffer from worms, they may have wounds and tropical diseases that can be controlled. And also antenatal care would be provided, child vaccinations. It would be manned by registered nurses, midwives, and doctors who are trained according to a recommendation that we've actually made. If that template was adopted, I can tell you, because it's cheap, easy to generalize, and it will prevent majority of people from ignorance, because we would collect data on them all the time. Children would come, we'll weigh them, we'll vaccinate them. If there was any epidemic, for example, there would be the health visitors who would go into the community and talk to people. And that would give us an opportunity to strengthen the hospitals, make them smaller and more efficient.
Thank you, Dr. We'll come back to you.
I recommend that article.
Brilliant, thank you very much. Dr. Sarah, you might want to say something about soap as well, because I'm sure the same problem goes on in Sudan and regional areas. But you have a specific question from Azim Al-Hassan, yeah, and it is, how do you evaluate the performance of MOSH in relation to the COVID-19 epidemic? Do you know anything about that?
I feel that that's maybe the Ministry of Health, the Federal Ministry of Health in Sudan. Maybe.
Oh, okay, so that's an abbreviation from.
If that's the case, I don't think I'm in a position to sort of comment. Okay. This will be unfair, but I will make some comments, general comments. But first of all, I think we have worked in a lot of, as I said, humanitarian aid before, in cholera, in chikungunya, in dengue fever, before 2019. When we worked to support Sudan, we didn't have a clue of what's going on. We didn't have information. We worked closely with the grassroots, and we were trying to support and help Sudan. Even organizations like the WHO, the reports were not clear about what's going on, was not reflecting what's going on. Now, the situation at the moment, we have transparency. We have clue of how many are sick, how many are dying, how many are recovering. So this is a huge step for us. We are aware of the protocols of the Ministry of Health. It is public. You can read it. There are challenges, definitely. I think countries like the UK is challenged by the COVID-19. And I think there are areas of improvement. How do we see ourselves? How can we fit into that as a diaspora? We fit under that by trying to provide support, advice, and technical sort of advice as much as we can. At the moment of COVID-19, which is like a war, we all have to stand together. It is not the time for just criticism, it's the time for unity and solidarity together. And I think there are a lot of examples that unity will help, standing together will help, and that's what we're trying to do.
Okay, and you are here referring to the wrangling political structures even within Khartoum. You're not even talking about the regions yet, right?
I think as we are, how can I put it? We're still sort of young, coming out from the revolution, okay. And we reached that by unity. I'm really sorry, but my son is around here. There's a bit of a noise, but I think there is no time at the moment people have just to think about one issue. How can we fight COVID-19? If we look at some of the examples, for example, one of them in Italy, which is a well-known example, when you had the politicians fighting, when they ended their fight, they discovered that they have lost a lot of people. And COVID-19, there is no time. So I think we will have to just get on with it, help and support, fill the gaps. And after that, we can come and make reflection and comments.
Brilliant, thank you. And in relation to that point, Dr. Marwa Jibril, there's a specific question for you. And it's saying that there is no primary health care in Darfur. There are no hospitals, rural hospitals, hardly. Why aren't doctors here not putting pressure on the government to provide at least hospitals? I suppose here he's talking about the Sudanese government. And it ties in with the point that Sarah is talking about, the non-politicization of the COVID-19 pandemic.
Right. So I would say it would be unfair, of course, to say that the current government is not trying. As Sarah said, we are just, it is a newly born government. We just came out of the revolution very recently. It hasn't been even 1 year since this government.
But have you specifically spoken to the government regarding primary health care and minimal health provision in Darfur?
Absolutely. So we have already, with the Sudan Doctors Union, we have had a meeting where we put all the plans for the vision of primary healthcare and for the whole healthcare system, but also in collaboration with people in Sudan, as it's not something that we would like to impose from health professionals who are outside of Sudan, but also in collaboration with doctors who are working on the ground and other health professionals. All these plans have been provided for the Ministry of Health, and of course it requires consultations. It takes time before a primary healthcare system is planned and then implemented. I think probably the coronavirus came and surprised everybody all over around the world, let alone the government in Sudan. But we are working. We're here even as a primary healthcare professionals, as a GPs in the UK. We formed a group to put also and have a regular contact with our counterparts in the Sudan Specialization Board. So the people who are in the primary healthcare training, we are providing regular training and mentoring, and we're hoping to build this collaboration to establish the primary healthcare in Sudan. I think it's a long path, but it also needs more stable government. It needs funding for training different health professionals. I think there is a lot of focus on the doctors, but I think the core of primary healthcare is also the other health professionals, the midwives, the health visitors, nurses, and all the caretakers. So I think also we need to invest on the other sectors as well, and not only training of the doctors. So I think the work is going continuously through the Sudan Doctors Union and through also our group as the GPs. But I think for us to see the fruits of this, it probably will be a bit of time.
The next question is actually for all of you, the three doctors. The question is that there is a lack of doctors and nurses in Sudan. And because of the COVID-19 epidemic, some hospitals have actually closed down because there's nobody actually to provide any health service. So what are you, North Sudanese doctors outside these two countries, in Britain and beyond, what are you doing about this? And also, when are you going to return so that you can make up for this gap in numbers?
Can I just pitch in? In 2009, I was approached by an American organization called Real Medicine Foundation in Los Angeles, because at that time I was running the St. Mary's Hospital where I worked on the Isle of Wight, Juba link. I established a link between St. Mary's Hospital and Juba Hospital, and we raised sufficient money to build a 6-bedroom, self-contained bungalow within the premises of Juba Hospital. And I personally felt that was the best way forward, because a lot of people from this country, United States or Scandinavia, can go overseas, pay for their own air tickets if you give them accommodation. And we had lots and lots of visits. People were coming round and helping, working alongside the doctors, carrying out some training, and also working with them to improve their skills. But we went a little further and established the College of Nursing and Midwifery in Juba. There was none. And this is a diploma awarding College of Nursing and Midwifery. The Japanese International Corporation for Assistance, JICA, saw our efforts and actually offered money to provide computers, electricity, and it was the only unit that had 24-hour electricity. Now we are generating people who can work in primary health care. Now, the Minister of Health agreed with everything that we were doing, and they were quite supportive. And up to today, the salaries of the nurses and the running of the college is still funded by RMF in Los Angeles from 2009. So for Darfur and
thanks a lot, Dr. Hakim. We are running out of time. It's a very good message.
You need links. You need links, and these links can be very effective.
Thank you very much. I'm not stopping you. It's just we're running out of time. I want Dr. Sarah Abdul to come in. Just give us a hint of what is the Sudanese doctors outside the country, and what difference would that make if they were to return, and what is stopping them?
So briefly, I can say before the COVID-19, we have already thought about this, and we have an initiative called the Sudan Health Volunteers, and we have collected a lot of information and linked with the Federal Ministry of Health. So if you want to go to Sudan just for a holiday, how can you help? If you want to go for a sabbatical leave, how can you help? Do you want to get involved in research, clinical work, public health? And obviously now with the COVID-19, we have to go back to this afterwards. During the COVID-19, as you know, the NHS have recalled even the retired doctors and nurses because of the shortage. And I have to say and salute my colleagues here who are working in the NHS and serving the communities. With the lock around Sudan, it is, I say at the moment, a little bit difficult for doctors to travel immediately because there is regulation. But what we are trying to do is to help the health professionals in Sudan to utilize PPE appropriately and training so that they will be supported. We have done an occupational health as well, sort of webinar, so that they can have some sort of support when they go to work, apart from the donation for where to stay and all of the other sort of support for them. I think overall it is multifactorial. When are we going to go back? That's a difficult question to answer, but definitely it is going to happen.
Thank you very much. Another challenging question before we close down. Unfortunately, time is running out. This is a challenge for all of you, the doctors. There seems to be emphasis on physical health, but why isn't mental health being discussed? Could you say something, Dr. Jibril? Could you unmute yourself, please?
Yeah, so I think mental health definitely come and plays an important role on this, and of course we are not mentioning it as we should. People with the lockdown, they are suffering a lot. There is a lot of loneliness. Of course, there is a lot of people who lost their incomes, and of course, as a GP, I'm seeing quite a lot increase in contacts due to mental health problems. Of course, the uncertainty that surrounding COVID, when is a lockdown is going to end, worries about family and friends, all that, of course, does impact on one's mental health. So the advice is, of course, for people to reach out to for each other, not necessarily to see each other physically, but through the phone and text message. So to keep in touch with their loved ones, asking about each other and how they are, and also important to spread the very positive message that we are going to overcome this. and that, you know, that there is better days to come. I think having the very pessimistic views about the whole situation is definitely impacting on all of us, our mental health, and we need to be more optimistic and spread the message of hope that things will get better.
Thank you very much. And a further message that you might all want to say something about it, including you, Dr. Kensley, is that, of course, the basic message regarding COVID-19 around the world now is not medical. It's about behavior, social distancing, personal hygiene. What effort is being done by both governments to make people aware of this, and what is the uptake of this? Dr. Kensley.
Yeah, I'll mute myself. I can only speak from the observations of the team. If we're talking about a South Sudanese governmental response, by formulating the task force and by promoting the instant move towards lockdown, I think the South Sudanese government was responding on a very kind of European model of control and of behavioural control that played into the South Sudanese government's strengths, which is kind of securitized population management. And I think that has been proven to not work, and also to raise other problems. And I'm looking forward.
Are people learning to social distance and to wash their hands?
So there are some studies that are showing that many people in urban areas are really trying to social distance and are trying to wash their hands. There are all sorts of wonderful initiatives from young people organising washing hands points and things, but these are things that are being organised beyond the remit of the government. And I think that's a really important point, that the government is not necessarily behind the things that are actually happening.
That message on. There's a lot of stuff on the radios, right?
Yes, and this is again all of these messaging pushes, which are great and are trying to reach into the rural areas, but at the same time that messaging is about defensive mechanisms.
Control. Dr. Sarah Abdul-Jalil, I would love to hear about, in relation to Sudan, about this, because this is what's going to save more lives, not the hospitals, right?
Definitely. There is variation, as we know, between urban, rural, and when we talk about refugees and camps. The messages that are going are very good messages, but what we need to do is the implementation and reality check that there are soap, there is clean water, and that people can stay at home and eat and drink because of the food security. You don't want people to develop malnutrition. We know that a lot of people in Africa, they depend on day by day sort of income. And therefore, if there is no effective economical bundle to support them, social distancing will fail.
Okay. On this note, I think we've come to an end. Unfortunately, there's still a lot of questions and still a lot of things to be said by all of you, I'm sure. But unfortunately, we've run out of time. So we just have to only have time to say thank you very much for your engaging discussion, and for our audience who also put the questions through. All we can say that you could see this is an example of two countries that are emerging from war, vicious wars that are still continuing, major economic challenges, and then also this on top now. So there's a lot to be said about people to learn more, messages to be sent to rural areas for people to learn how to protect themselves more. We have to recognize the traditional methods of self-protecting. Governments have to do more than just push people by force. So these are just huge challenges for countries like Sudan. And there are more challenges beyond health, just like you mentioned, Nick, that people say we cannot even deliver children while we're talking about, the epidemic. So we should say thank you so much, and thank you for watching as well.
Thank you very much. Thank you.